I discussed about the CAR T-cell immunomonitoring aspects and also what should be important to monitor based on the data that are available in the literature, and also what are the challenges related to this procedure in the real life world. So we know that several monitoring studies performed during the first trials that led the approval to CAR T-cell therapies showed the interest for the characterization, for example, of the apheresis product to assess clinical responses, in particular showing that the enrichment of CD8 and memory stem cell specificities were associated with clinical phenotypes of complete responses, and also a few high-impact studies covered the question about the efficacy of the transfection with viral vectors and ex vivo expansion, showing that depending on the site of the CAR gene integration on the genome, the expansion of CAR T cells in the patient could be successful or not. Of course, once CAR T cells are infused in the patient, also the dynamic of this expansion represents a key feature and has been shown as a key factor for the clinical response. Indeed, the starting point was that it is important to monitor CAR T cells, but the problem is that procedures are not standardized, and a lot of a source of recommendation actually is lacking. So we therefore decided to run this survey on behalf of the CAR T of the Cell Therapy and Immunobiology Working Party of the EBMT to capture a sort of snapshot of the current monitoring practices in European centers as the basis for this harmonization process. The preliminary analysis of this survey, as I presented during the session, has shown that there is a lot of variability among monitoring practices in European centers, and consequently, several centers could monitor several subsets of CAR T-cell or non-CAR T-cells, or IgG reconstitution, or cytokine and inflammatory markers. As well, there was heterogeneity also in the timing for the monitoring. As a matter of fact, only 60% of the center perform immunomonitoring in CAR T-cell, which was actually a striking point. We expected a little bit more, and few centers used immunomonitoring techniques to drive clinical practices. As concerning the platforms, standard flow cytometry seems to be the most used platform in the previous months after CAR T-cell injections, while PCR-based methods were used for especially later time points. And about 50% of the centers have integrated also the study of more specific T-cell subsets, such as T-naive memory cells or regulatory cells, both for CAR T and non-CAR T fraction, but most of the centers run these immunomonitoring studies only on CD4, CD8, and in the non-CAR T-cell fraction, NK, and also B-cell as additional subsets. But the answer to the crucial question about whether the immunomonitoring was used to drive clinical decisions showed that most of the centers use these studies only to drive interventions such as IgV prophylaxis or other anti-infectious prophylaxis, while a few centers adapt, for instance, to the immunomonitoring studies, the treatment for CRS or ICANS, or the patient discharge time. So we think that the results of this survey could be very useful for a consensus paper on how to harmonize the implementation of routine immunomonitoring, and we are actually working on that.